My watch says it's 6 o'clock, and looks like we have an attentive audience tonight. I want to welcome everyone in the audience in person tonight to the, I guess it's called Diabetes Basics 101. We also have a virtual audience. This is being streamed, and I assume it's being recorded as well if someone has an interest in that. But I don't know how many of you have been into this beautiful center, CMC Center for Learning and Academic Medicine, but this is a wonderful space or this type of activity, and a lot goes on in this building, and when you have a chance sometime, hopefully you can get a tour to see some of the offices, and the simulation center is upstairs, but we feel fortunate to be able to use this. My name is Dan Foster. I see a lot of familiar faces, and I know a number of you. I'm sure many of you don't know me. I'm a retired surgeon and also worked in administration here at CAMC for a number of years. But I've been fully retired for almost 6 years. But I enjoy coming back to participate and help moderate these community events, which I think are important to public health as well as to the understanding of what goes on in this large facility. The mini med school series goes back many years, probably almost 40, I think. And it was initiated by a gentleman named Dr. Joe Skaggs. I'm sure many of you remember him. He was a role model for me, but he did this for a number of years, probably 15 or 20. And then when he departed, it just stopped. But it was resumed after being dormant for those years about 10 years ago. And we've been doing these about twice a year. And it's been our plan to address topics that we feel are important, but also based on your input. And hopefully, in some way, I don't know if you'll be getting surveys, but we want to hear how you think the program was, as well as what we should be doing in the future. And it helps us to decide what we're going to do the next time. The most important thing is to thank you for coming, because we love to see you. Even it's a beautiful evening tonight, but this is important, we think, for many people in this state. And hopefully, and I'm confident that this information will be useful to most of you, for sure. A few housekeeping measures. The bathrooms, which is very important, are right across the way here. I hope many of you got some food. The food will be out there, I assume, for a while, food and drink. There are also some folks in the back with exhibitors or vendors, whatever you want to call them, one from the volunteer services, and we'd hope that some of you would be interested in volunteering at Charleston Area Medical Center. There's a group from case management who are dealing with what are advanced directives, which are what I would call living wills and other designations of what you want done if something should happen to you. But everybody should have that in their file, and they can help you do that. And then they're taking blood pressures back there over in the right corner, and they also have some swag of various sorts that you might want to take with you. We have one major sponsor who has been involved with almost every one of these, at least in the last 10 years, and that's the Charleston Area Medical Center Foundation. Brian Cummings is the president, and we appreciate their willingness to support this financially in outreach from them and from us. You have, I don't know if he mentioned to you, we're going to have a Q&A session at the end. But during the middle of the presentations, if you wouldn't mind writing questions down, and somebody will raise your hand and somebody will pick them up. And hopefully we'll have 30 or 40 minutes for questions at the end. I anticipate there being many. We are fortunate to have 3 excellent presenters tonight. And some of you may know one or two of them. I just met a couple of them this evening, although one of them I think I may have met years ago when he was in medical school. Jeremy Soule is the first speaker, And then Dr. Asif Rahman will be our second speaker. And the third will be Dustin Holmes, who is actually a nutritionist who will be talking about that aspect of diabetes care. According to the American Diabetes, and at the end, we'll put them in a panel over here, and that's when we'll ask the questions. They'll all three be up there, and hopefully that may be almost the most important part of this evening. According to the American Diabetes Association, about 223,338 people in West Virginia, or approximately 15.7% of the adult population, have diagnosed diabetes. They know they have diabetes. I think that number's low, but that's what we're told. It is also believed that an additional 45,000 people have diabetes and don't know it yet. And that's unfortunate, because this is a problem that can be dealt with reasonably well if you know about it. That being said, let's move forward, and I want to introduce our first speaker, Jeremy Soule, who is a native of, as he describes me, Maryland, the suburban Washington area, as well as the Eastern Panhandle, and received a BA in biochemistry at the University of Maryland. He then received his MD from the WVU School of Medicine while spending his last 2 clinical years here at WVU Charleston, where he met his wife, who is a native of Putnam County. That certainly helped him getting back here, I assume, eventually. He completed his internal medicine training at CAMC and WVU across the street. Jeremy then went to the other Charleston, South Carolina, where he completed a fellowship in endocrinology at the Medical University of South Carolina, and joined the faculty there, where he worked at the university as well as the affiliated VA Medical Center. And while at MUSC, which is the Medical University of South Carolina, he participated in clinical research focused on diabetes, including serving as a local investigator for the Diabetes Control and Complications Trial follow-up study, as well as the Veterans Affairs Diabetes Trial. Fortunately for us, he and his wife returned to West Virginia in 2011 and initially lived in Bridgeport, where he worked at the United Hospital Center. And in 2020, he returned to WVU and CAMC, where he now serves as the endocrine section chief. He's going to give us a brief background on diabetes and what this entity is in its various forms. I'll give you Dr. Soule.
Thank you very much, Dr. Foster. Thank you, everybody, for attending, and I really appreciate the opportunity to be here. I'll be talking today about just kind of the basics of diabetes, about the diagnosis of it, how we diagnose it, why we diagnose it the way we do, and how we treat it. I'd like to start off with a slide that's very similar to the one you've already seen. I think this data is a little bit newer than the data that Dr. Foster showed, because you can see the numbers of people with diabetes is a little bit higher. So this is something that the ADA puts out. They look at the burden of diabetes in every state, so you can pull it up state by state. And this is the West Virginia data. And I think this dates back to about 2021. Couldn't find anything more recent, actually. But by that time, we were up to 16.2% of adults having diabetes. And again, you know, about a fifth of people didn't even know they had it, so 45,000 people. There's also a huge problem with pre-diabetes. These are people that have mildly elevated blood sugars, and they face varying degrees of risk of progressing to type 2 diabetes with time. And that number of people is usually about twice the number of people who actually have diabetes, have pre-diabetes. I do a lot of work in the hospital, and the data I've seen, it's been a few years, but up to 40% of the patients in the hospital will have issues with diabetes or elevated blood sugars due to treatments they're getting while they're in the hospital. So it's a huge problem clinically, and as an endocrinologist who was always particularly interested in diabetes, you know, it takes up a big part of my work life. Okay. It's also a very costly disease. It costs over $2 billion to West Virginia annually. And what we really worry about with diabetes, we'll be talking about the numbers, but what I'm trying to trying to get across is the numbers that we talk about all the time in clinic and tell our patients to strive to achieve. We do that because we're trying to prevent the complications. And unfortunately, diabetes has a lot of really serious complications, and we'll talk more about those, but they're very, very manifest in our community. So first of all, let's talk about what diabetes, and this is a nice lay-oriented definition. All this data is available online. And by the way, I'm happy if my slides are made available. They're all hyperlinked to where I got this from. But this is a pathologic definition of diabetes. This is put out by the CDC. And basically, diabetes is a disease that affects the metabolism of food. There's a problem with how food is processed and stored with diabetes. So almost all the foods that we eat can break down into sugar, into glucose, what we measure in our glucose meters. And usually what happens if we're not diabetic is the pancreas does a very, very good job of monitoring the glucose levels, and as they get minimally elevated, releasing insulin. And this insulin percolates out through the body. It acts like a key to unlock cells in the liver and the muscle to absorb and store the glucose. And what happens in diabetes is the body doesn't make enough insulin, so the cells can't get those signals, or for whatever reason, the cells that take up glucose can't hear that signal. They're resistant to the insulin. And as a result of that, too much blood sugar remains in the bloodstream. And blood sugar over time, unfortunately, is toxic. And that's what leads to the problems that we worry about with diabetes: the heart disease, the vision loss, the kidney disease, the neuropathy. I often have to, particularly early on when I'm trying to take care of patients, I try to remember to step back and explain why we're trying to do what we do, because I think even for myself sometimes when I look back at my day, it's been a lot of numbers, and you kind of separate yourself out from why we're motivated to do this. But so let's talk about some of the numbers, and let's talk about diabetes, what it means numerically in terms of blood sugars. And I'm going to tie that to complications with an older slide that I think is really interesting. But so numerically, there's ways to measure diabetes based on blood tests, and there's 3 tests that we use. Is everybody familiar with the A1C? I'm not sure how many people have diabetes or know someone who does, but so the hemoglobin A1C is a measure of average glucose levels. It's the amount of glucose attached to red blood cells. And one of the ways we can measure diabetes and diagnose it is by looking for people who have an A1C of greater than 6.5%, and that's considered diabetes. Normal is less than 5.7. Okay, another thing that we often look at is fasting plasma glucose, and a level 126 or higher is considered diabetes, particularly if it's repeated. We use 126 and not 125 because 7 millimoles per liter is 126. And that's what everybody else in the world uses who's on metric. We don't do glucose tolerance testing as much as we used to. Maybe we should do some more of them, but another way to measure glucose and diagnose diabetes is with an oral glucose tolerance test, and a blood sugar above 200 2 hours into that test is considered diabetic. And then also anybody who's presenting with classic symptoms of diabetes: blurred vision, thirst, increased urination. If they have a glucose level greater than 200, you want to confirm that, but greater than 200, that would also be considered diabetes. But I think for the most part, people are mainly looking at the glucose levels that we see on routine labs and then getting an A1C when something looks suspicious. So where do those numbers come from? Again, there's a lot of numbers with diabetes, but this is a very interesting study in my mind, and there's a lot of different studies like this. But so we're worried about complications. We don't want high blood sugars, not because of just the number, but because of the complications. And the 3 big target organs we worry about in diabetes, and there's a lot of other target organs, but we really think about the eyes, we think about the kidneys, and we think about the nerves. And you can get a urine test. Dr. Rahman can measure protein in the urine, and maybe he can correct me if I'm wrong, but if you have protein in your urine, that in and of itself doesn't tell you that the protein in the urine is from diabetes or something else. It's a lab finding. Similarly with nerve problems, there's a lot of problems that can lead to nerve problems besides diabetes. But the eye doctors can look in the back of the eye and say, there's a problem with that retina, and based on what it looks like, I'm almost sure it's due to high blood sugars. So where do those diagnostic criteria come from? Are from large population studies, like this one that was done in Pima Indians, and the eye doctors looked in the back of the eyes. They either saw or didn't see eye changes, and they correlated that to blood sugar values, including the 2-hour post-glucose tolerance test level, the A1C, the fasting plasma glucose. This has been done with the Pima Indians in Southwest America. It's been done with NHANES, very famous Egyptian trial. But wherever you look in the world, if you look for diabetes in the back of the eye and then you correlate that to blood sugar measures, it correlates very closely to those diagnostic thresholds. So that's where that comes from. So I always thought that was interesting and motivating to want to go out and both diagnose diabetes so we can do something about it and treat it and lower those numbers. Okay, there's many types of diabetes. The two most common ones that we talk about all the time are type 1 diabetes and type 2 diabetes. Type 1 diabetes is an autoimmune disease where the pancreas cells that make insulin are destroyed by the immune system. And it's about 5 to 10% of people with diabetes. Classically, we think of it as being in children. We still often think that, but in actuality, about half of type 1 diabetes occurs in adults, usually in younger adults, but it happens a lot. In adults, it's often a more slow onset, can be kind of stuttering, and we call that latent autoimmune diabetes of adulthood. This is a huge thing for endocrinology practice because we have people who have been struggling to get under control for their type 2 diabetes, and we'll assess to see if they have type 1, and it's not that infrequent that we find that. I'd say it happens, every month or so to most of our practitioners. So type 2 diabetes is the more common type of diabetes. We used to think of it as being adult onset. We are seeing it, unfortunately, we're seeing it more and more in kids and mainly adolescents. As our population gets heavier and heavier and less active, it's becoming more of a problem. But about 90% of people, 95% of people have type 2 diabetes. And this is the one that's in the past was considered non-insulin dependent. Okay. There's also many other types of diabetes. I just wanted to, I thought there was a lot of pretty colors, and give me a way to point out that there are more unusual types of diabetes. So, for instance, the KPD type of diabetes is ketosis-prone type diabetes. It can occur. Some people with type 2 diabetes will get ill and almost act like they have type 1 diabetes for a while and have ketoacidosis. Other things that this is pointing out is there's types of diabetes that occurs in families, like MODY stands for maturity onset diabetes of youth. So it's people who present in their 20s or teens with what looks like type 2 diabetes, and it runs very strongly in families. So this is probably about 5, maybe 10% of patients have these types of diabetes that have been termed atypical. And we know when you're in an endocrinology practice, your practice is enriched with these kinds of patients, and they can be challenging to diagnose, but the diagnosis will guide your treatment a lot. So why do we care so much about diabetes? We've already talked about the issue with the complications, and diabetes complications really cause severe illnesses, and treating this reduces complications. I was started medical school in 1990, and I remember in my introduction to clinical medicine class, the professor said, unfortunately, diabetes has horrible complications, and we can't do anything about it. It doesn't matter what you do, it's horrible. Well, within a year after that lecture, we had the first study come out that showed by controlling glucose levels, we can really mitigate risk of complications, to the point now that people who are well cared for with type 1 diabetes can live long, full lives without symptomatic complications. So we usually talk about diabetes complications both in terms of large blood vessels and small blood vessels. Small blood vessels, or microvascular disease, is what we think about when we talk about eye disease with retinopathy, with kidney disease and renal failure, and with nerve disease, which leads to pain in the feet and can progress to foot infections and amputations. Macrovascular disease, that's large blood vessel diseases. heart attack, strokes, peripheral artery disease, problems with blood circulation in the legs. Unfortunately, this is still a huge problem. Things have gotten a lot better over the last 30 years or so since that trial came out that I talked about showing that you can improve outcomes, but diabetes still remains the leading cause of adult blindness, the leading cause of end-stage renal disease in adults, and it's also the major cause of non-traumatic amputations. So still a huge, huge issue. Having untreated diabetes also doubles to quadruples your risk of heart attack and stroke. So still a huge, huge issue, but with some really good news about treatment. So reducing risk by reducing elevated glucose. This was a study that came out in the late 90s in type 2 diabetes. It followed a study of type 1 diabetes that I'll talk about in a minute. But what this study is showing is that by taking patients and treating them intensively with diabetes, trying to get their A1C normal versus just letting things take their natural course, the actual, when we do clinical trials, we have control groups that aren't treated, and the control at that time was to prevent symptoms. Don't overtreat patients and cause low blood sugars, and as long as they're not really thirsty and peeing all night, you don't have to bring the blood sugars down too much. So that was the control group. And what this shows is the relative percentage of people who developed microvascular disease who were in the treatment group versus the control group. Towards the end of the study, that's the red bar there. This is a little bit technical. I hope you guys, I hope I can articulate it well enough, but you can see that center of that red bar is at about 0.78, just below 0.8. So over the course of this study, A1C was a little more than 1% lower in the treatment group, and that resulted in a approximately 25% reduction in complications. So what was found in that study was that for each 1% the A1C was decreased, the risk of complications went down by about 25%. In that study, unfortunately, it wasn't proven that reducing blood sugar improved the risk of heart attacks, although there was a strong trend for that. But that's something that we had to wait until about 10 years ago to have really good data about diabetes treatment reducing the risk of large vessel disease. Okay. This was the study that I talked about. It came out initially in 1993, which was a year after that lecture that I told you. And this was a diabetes control and complications trial, and it was a study of type 1 diabetes trying to normalize blood sugars versus letting the A1C run about 9%. And what they found is, again, by reducing the A1C by about 1 percentage point, you would get about a 25% reduction in complications. And what this slide shows is it breaks down different curves based on A1C. So this is somebody with an A1C of 7% versus an A1C of 11%, and in the middle we've got 10, 9, and 8. And this is time. And what you can see is by keeping the A1C down towards target levels, very little progression in retinopathy over the years, versus unfortunately, as you get to 8, 9, and when you get to even higher A1Cs, the risk of complications goes up quite quickly, so that you're seeing 25% risk over the course of 5 or 6 years with the higher levels. So this was a real boon for patients with diabetes, and it really motivated the healthcare system to step up and try to get people under much, much better control. And this was the time when I was doing my training in medicine and endocrinology in particular, so it was pretty exciting. So how is diabetes treated? We're going to talk just about general targets. Care is always individualized, but what we in general shoot for is an A1C of 7%. 6.5% is used by a lot of clinicians, though, and we individualize that based on people's risk. So, for instance, if somebody is really prone to low blood sugars, let's say they're passing out from hypoglycemia, you would maybe relax that a little bit and let the A1C drift up a little bit higher than 7%. If somebody is younger, they're trying to get pregnant, we might try to get their A1C down less than 6.5%. Unfortunately, historically, there's been a trade-off between having low sugars and keeping the A1C down low. More recently, the technologies are getting so good that we can often get the A1C down very low without hypoglycemia or much other side effects. But this is sort of the general targets that we aim for. To get an A1C of 7%, you've got to average a blood sugar of about 154, and that's associated with blood glucose levels of 80 to 130 before meals and less than 180 after meals. And you can see those are very, very similar to the numbers we talked about for the diagnostic thresholds. And that goes back to, we're aiming for these numbers to reduce complications. Okay. So how is diabetes treated? It's become very, very complicated. This is the latest version of the American Diabetes Association guidelines. Dustin's going to talk a little bit later about diet, but I'll point out that the foundation of diabetes care is lifestyle measures, particularly diet. So I've highlighted that at the top. It's very, very hard to address diet in a doctor's office. We just don't have enough time. It's just the reality. I try to focus on looking at high-yield things in the patient's diet that could be changed, and I also will often talk about the diabetes prevention program. The diabetes prevention program is just good general measures for diet, whether or not you have diabetes or prediabetes or just a normal healthy adult. The diabetes prevention program found that by having people exercise 150 minutes a week, that's just 30 minutes, 5 days a week, and by losing about 5 to 7% of their weight, people were able to reduce the risk of diabetes by about 50%. I think that this study came out in the 90s, but in any event, the Center for Disease Control really got on board with this, and there's all sorts of programs in the communities and also online focused on taking these measures nationwide to try to reduce the risk of diabetes. You can look up CDC Diabetes Prevention Program if you're interested. And then beyond that, we usually refer to a dietitian to help us out with the role of diet in diabetes. But as a physician, often what physicians do is we're the ones who can prescribe, and we're focusing on drug therapy. And this has really been exciting over the last 10 years or so. We have a lot of older medications. They all lower blood sugars. Insulin, there's a class of medicines called sulfonylureas, which is glipizide and glimepiride, Amaryl. I'm sure people have been on that. Metformin. Januvia is a DPP-4 inhibitor. Those are just some of the common ones. They all, to lesser or greater degrees, can lower glucose, and they would reduce the microvascular complications by doing that. But beginning in 2015, we started having medicines that were coming to market that were shown not only to reduce glucose, but also reduced complications independent of glucose. So for instance, empagliflozin, I believe, was the first one back in 2015 that showed it reduced cardiovascular events, particularly sudden death, while also lowering glucose. And then Victoza, which is still used, it's kind of like the forerunner of Ozempic and Trulicity and Mounjaro. Victoza was shown to reduce cardiovascular events while also having good effects on blood sugars. So beginning back in the mid 2000 teens, we started having medications in these two classes that were shown not only to lower blood sugar, but have an impact on cardiovascular disease. In these studies, it was also found, particularly with the SGLT2 inhibitors, which include, the empagliflozin, which is Jardiance, the Farxiga and Invokana. I'm sure people are familiar with these. We also started seeing data that they really had a profound impact on heart failure and kidney failure. They were very protective against kidney disease and heart failure. So the latest guidelines, the ones that I just showed you, and I'll show you again, what they recommend is that this is such a busy slide that it's hard to project it well. But what this is trying to show is that beyond lifestyle measures and looking at social support and things that are very important in our home environment and work environment, the next thing we do is we look and see, does the patient have any compelling reason to be worried about chronic kidney disease, heart failure, or atherosclerotic cardiovascular disease, risk of heart attack or stroke. And that's where we start with the treatment nowadays, because if people have trouble with heart failure, we would look at the SGLT2 inhibitors, which have been shown to be very, very effective in that setting. And again, that's the Farxiga and Jardiance and Invokana. Chronic kidney disease, again, that same class of medicine has shown to be very efficacious in slowing kidney disease. If people have more problems with heart attacks or strokes, we often will start with the GLP-1 drugs, which are Victoza, Ozempic, Trulicity are the ones that have been proven to reduce those risks. So things have gotten fairly complicated. We still have all these older, more classic medicines that do a really good job of lowering glucose, but haven't been shown to have those specific effects on lowering really key diabetes complications. So in conclusion, diabetes is a metabolic illness which increases glucose, and that causes characteristic complications. And we talked about the diagnosis and glucose treatment targets for diabetes. And those both harken back to that retinopathy data and the fact that we choose those thresholds to try to ultimately prevent complications in our patients. And fortunately, over the last 10 years or so, we do have newer medicines that not only lower glucose, but independent of lowering glucose, seem to be lowering key diabetes risks and also just health risks in general. And we just talked about that with the SGLT2 inhibitors and GLP-1s. So it's a really exciting time to treat diabetes, and we have better tools now. I've focused on the treatment of type 2 diabetes, but we have great new tools for type 1 diabetes with closed-loop insulin pumps and sensors and all sorts of exciting things. But I appreciate your time, and I guess we'll have questions and answers later on. Is that right? Okay.
That's correct. Thank you so much.
Thank you.
Dr. Soule. That was a wonderful presentation and certainly sets the stage for the rest of the evening. I remind you again, write down your questions and raise your hand and somebody will pick them up, because I'm sure there are many questions that are still out there. I would note that it's just a little over 100 years ago that insulin came to be a part of our armamentarium for type 1 diabetes. And before that, diabetes was a death sentence. So it obviously is no longer that. And as Dr. Soule has eloquently described, just getting basic treatment of various sorts can give you a virtually normal lifespan now with diabetes. Our next speaker is Dr. Asif Rahman. Dr. Rahman was born in Geneva, Switzerland, received his higher education in India, obtaining his medical degree from JN Medical College in 1975. He trained in pediatrics and medicine at Jewish Hospital and the Medical Center of Brooklyn in New York. His nephrology and hypertension fellowship was completed at North Shore University Hospital in Manhasset, New York in 1983. Before coming to West Virginia, he finally got here. Just took him a little time. We're delighted to have him here. For 41 years, Dr. Rahman has been in the private practice of nephrology at Charleston Area Medical Center and a member of the clinical faculty of WU Charleston. During this time, he received multiple clinical faculty awards at WU Charleston and served as Chief of Staff at CAMC in 2010-2011. He is very proud of the Nephrology Endowment Fund that he created at the CAMC Foundation for the purpose of helping patients, families, residents, and programs with some renal connection. We are delighted to have him tell us about the all-important connection between diabetes and the kidneys. Dr. Rahman.
Thank you, Dr. Foster. I was told there is a clicker here. Dr. Soule mentioned that a certain percentage of his patients develop complications. All my patients with diabetes who come to me, 100% of them have developed complications. And for 41 years, I have seen things in these patients that Dr. Soul has described, the eyes, the blindness, the kidney failure, the dialysis, the legs that have been lost, the limbs that have been lost. So, yes, we absolutely must prevent this. And this is a slide from the National Kidney Foundation that I found on Google. And I said that this is the way to do it sort of backwards, where I answer questions that you might be thinking about but be reluctant to ask. So preventing diabetic kidney disease by the National Kidney Foundation, and let's answer 10 questions. Oh, wrong way. What causes it? We have heard Dr. Soul say about diabetes and how diabetes is a abnormal metabolism of sugar. But how does diabetes affect the kidneys? This is the one and only complicated slide. In the kidneys, blood goes in, blood comes out. And while it does that, it gets rid of many, many waste materials and keeps all the good things inside, right? And that happens because deep down inside the kidneys, there is 1 million filtering units, and each filtering unit is called a glomerulus. Big word. A glomerulus is a bunch of teensy-weensy little blood vessels that Dr. Soul mentioned was microvascular, teensy-weensy blood vessels, and they are like a colander, The good stuff stays inside, the bad stuff comes out. The bad stuff comes out. In diabetes, it is these little holes of the colander that get damaged, and they start getting bigger, and they start getting bigger, and we start losing something called protein. So if you have protein in the urine, as a patient, something has happened that has damaged that colander or that glomerulus. Protein in the urine is a sign of kidney damage. Protein in the urine. Now, little bit of protein, all of us in this room, normal, non-diabetics, diabetics, a little bit of protein is normal. But when that little bit starts to become more than a little bit, that is abnormal. Protein in the urine is a sign of kidney damage. And it happens because there has been damage to that little glomerulus, that little tuft of blood vessels that has now allowed to leak good stuff, not just the waste material. Are some people more likely to get diabetic kidney disease? Unfortunately, yes. So who are these people? Not all diabetics get kidney disease. Dr. Soul mentioned that there is a genetic connection, right? So if many members of your family, you might be prone genetically to get kidney disease. High blood pressure, very important. People with diabetes and high blood pressure are more prone. People with diabetes and abnormal. I'm repeating what Dr. Soul has said. He showed you the 7%, 8%, 10%. The less well your blood sugar is controlled, the more likely you will have complications, the more likely you will have kidney disease, the more likely you will end up seeing a kidney doctor with one of the complications of eyes, kidney, nerves. The microvascular disease. We are not even talking about the strokes and the heart attacks and the loss of limbs. So there is microvascular, that's macrovascular, right? So high blood pressure in diabetics, poor glucose control, genetics, and of course diet, which we will come to again later on. We keep repeating the same thing again and again. I have diabetes. How do I know that I am affected or not, right? I had mentioned that early on, we don't know. And then you may have some swelling in the legs. That is a sign of further damage to the kidneys. And when that process starts to continue, there may be signs and symptoms of kidney failure. And we don't want to go there right now because we are talking the early stages. Just that is a sign that something has changed in your body and you are starting to retain fluid. And there are many causes of that, but that is a sign that something is happening. Are there tests that can be done to tell if I have kidney disease? Absolutely yes. So initially, and we have hopped on this, Leakage of protein in the urine, also called proteinuria. A protein, the other name for protein is albumin. So albuminuria, albumin in the urine, albuminuria. Protein in the urine, proteinuria, right? So that can be easily checked by your physician and should be done on a regular basis if you are a diabetic to see if you are leaking protein in the urine. Protein in the urine equals damage to the kidneys. Again and again, I go back to that. Later stages, remember, normally the kidney gets rid of waste material and keeps the good stuff inside. When that waste material, also called blood urea nitrogen, or commonly known as BUN, or a different waste material called creatinine, begins to rise in your blood, that can be checked by a blood test. So a simple blood test can tell you that it is beginning to rise. And somebody, I stole this from someone, I don't remember who, but they say protein in the urine is a sign of kidney damage. A high creatinine in the blood is a sign, the beginning sign of kidney failure. So creatinine and BUN, more so creatinine than BUN, should be checked and can tell you whether your kidneys are being affected or not. We then take this creatinine number and take the age of a person, the sex of a person, and we put it in a computer and we mix it and we come up with a number. And it is called, this is technical, estimated glomerular filtration, or your GFR. It is a very loose association with percentage of kidney function. Very, very. But it is important to know, because you can ask your doctor, what is my GFR? In fact, all labs that you get blood work done automatically give you a GFR. So they know your age, they know your sex, and they know your creatinine. They put that in the little computer and spit out a number, and you have a GFR, right? And a GFR of over 60 is considered pretty normal. A GFR which starts to decrease, a GFR which starts to decrease, you have kidney disease. Based on the GFR, this is the only complicated slide that I will show you, based on the GFR and the albumin or protein in the urine, we have devised this heat map which tells us whether somebody is in a stage 1, 2, 3, 4, or 5 kidney disease stage. Chronic kidney disease, also called CKD, if your GFR is less than 15, is stage 5, the worst. Stage 4 is 15 to 30. Stage 3 actually has been divided into 3A and 3B. 3A being better than 3B, from 45 to 60, 3B being 45 to 30 below. Stage 2 and 1 are 60 and higher, and the only reason they are considered to be chronic kidney disease is there is something more than that GFR, and that more than the GFR is protein in the urine. Protein in the urine. And as you go to the right, there is more and more and more protein. So the person with the highest amounts of protein is at highest risk for developing worsening kidney failure. Why? Protein, because it indicates damage to the kidneys. More protein, more damage. More damage, more progression. And those are the people who need to watch themselves more carefully, right? So very, very crucial. How long does it take for kidneys to become affected? Everybody may be wondering this. Type 1 diabetes, about 2 to 5 years. 30 to 40% of them progress to more serious disease in 10 to 30 years. So you can imagine that it takes a very long time. There is time to control these complications of diabetes, but you have to be careful about that. Type 1 diabetes, there is a syndrome called retinal renal disease. What is happening in the eyes is happening in the kidneys. You may not know it, but if you go to your eye doctor and says there is diabetic changes out there, you can say there is diabetic changes out there also. Same microvascular, same teensy-weensy blood vessels that are in the eyes are in the kidneys. Diabetes doesn't pick places. It is affecting all the blood vessels in the whole body. So if the eye doctor can see it here, it is happening there also, and elsewhere, wherever there are teensy-weensy blood vessels. In type 2 diabetes, we don't know because we don't know when it starts. But anywhere from 5, 10, 15 years, if you have type 2 diabetes, you are at risk for developing kidney disease as well. What can I do to prevent kidney disease? Control your blood sugar. Dr. Soul mentioned that again. Get that A1C down level. Get that A1C below, whatever. You and your doctor establish a goal for your A1C, right? For me, it may be 5%. If I'm pregnant, it may be lower. If I'm old and falling down and collapsing, it may be higher. But you and your doctor decide on an A1C level and keep it there or below that, right? Keep it there or below that. Healthy diet, physical activity, smoking cessation, and weight management. Lifestyle changes go a very long. Dustin is going to talk about that in just a little while. But physical activity, doctor, 30 minutes a day, 5 days a week, a great place to start. If you can do more, even better, right? So lifestyle changes. Everybody needs to stop smoking. I mean, it just doesn't help anything. You make the tobacco companies rich, you pollute the atmosphere, you give yourself asthma, but it also affects your blood vessels. So please encourage everybody to stop. If my kidneys are already affected, can I keep them from getting worse? Absolutely, right? Control of your A1C, control of your A1C. I'll repeat the control of your... Now, the second one is control of your blood pressure. It used to be 130 over 80. There was a big trial called the SPRINT trial. You don't need to know about it, but they said control it to lower levels, 120 over 80. Here is a little secret that I will tell you, right? It is called physician inertia. What that means is that I am your physician and I say, 128, oh, it's all right, you know, you're okay. No, you're not okay. You demanded of your doctors, please get my blood pressure down to below 120. If you are feeling well, if you're dizzy and passing out, absolutely not, right? But if you are feeling well, the numbers have shown that a systolic or the top number level should be below 120. And don't let your doctor get away with, it's okay. That is not right. Hemoglobin A1C, if you're endocrinologist and you have decided on a specific number, your primary doctor should not be okay with something more than that, right? It is your body, it is your life, it is up to them to get it down to below a certain level. Also, control of cholesterol is important. And then there is a specific thing about a low protein diet. People who have established kidney disease from diabetes might be helped if they reduce animal protein, especially red meat protein in their diets, to a little bit. Don't stop it. Don't stop living. Enjoy yourselves. But instead of having an 8-ounce steak at every party, have a smaller steak at every party, right? So a low protein diet might help prevent your kidneys from getting worse. Are there any new treatments that can help me? ACE inhibitors and receptor blockers. The ACE inhibitors have been out since the mid-1970s, I should say. And when I came to town, they were absolutely out. Then they came with the receptor blockers, and that's lisinopril, quinapril, losartan, valsartan, olmesartan. All these are receptor blockers. They are specific for the treatment of high blood pressure. So while there are many other drug classes for the treatment of high blood pressure, these are specific for the treatment of high blood pressure and for the treatment of kidney disease due to diabetes. And this is independent of blood pressure control. Dr. Soul mentioned the flozins, the SGLT2, independent of the control of blood sugar or the help it might provide. It has been shown that the flozins help the heart and help the kidneys. So once again, ask your doctor if you are a candidate for the treatment with an SGLT2 blocker or a flozin. Ask your doctor about this. How many people with diabetic kidney disease develop total kidney failure? I'm sure you're wondering. Almost 30% of people with type 1 and 10 to 40% with type 2 will develop end-stage kidney failure. High number, and we got to try everything not to be part of that statistic, right? You got to want to be the 70% who don't develop. And we have already talked about the ways you can do this. If my kidneys do fail, what can I do? To maintain life, a person with kidney failure can receive artificial kidney treatments called dialysis. Dialysis will not rejuvenate your kidneys. Dialysis takes the place of your kidneys. Dialysis does what the kidneys should have been doing. It's a way to live without kidneys. It doesn't do anything. Once the kidneys are gone, the kidneys are gone, right? And the only other option at that point is get a new kidney, called a kidney transplant. Dialysis can be done through the belly, can be done through the blood, called peritoneal dialysis, hemodialysis, and all can be done at home. It's not the end of the world. It does put some restrictions on your life, but it is definitely not the end of the world, so things that don't have to end and you don't have to call your undertaker or something, right? So this is the final slide of mine, which basically shows that you start off at the bottom of the pyramid: diet, exercise, smoking cessation, and weight. That's where your Ozempics and the Mounjaros come in. The next one is the medications that can help you with your diabetes. The third one is sort of technical, but finally in the top, glycemic control is sugar control, blood pressure control, less than 120/80, and then lipid management or cholesterol control. So these things all together hopefully will extend a life, extend the kidneys, prevent eye disease, neuropathy, and so on and so forth. And I will leave that for the end. Thank you all so very, very much for listening.
Thank you so much, Dr. Rahman. Great presentation. If there are any questions he hasn't answered, please put them on the card and send them over, and we will start putting those together here relatively soon. Our last presenter is Dustin Holmes, who is a dietitian and a nutritionist. And we are delighted to have him with us to provide advice on managing and otherwise dealing with various forms of diabetes using the nutritional route. Dustin is a native of Eastern Kanawha County, earned his Bachelor of Science degree in dietetics, from Kansas State University, and completed his dietetic internship at Marshall University. He is now employed at CAMC and is nationally recognized as a registered dietitian nutritionist that specializes in educating and counseling those with various chronic conditions such as diabetes, heart disease, chronic kidney disease, chronic obstructive pulmonary disease, obesity, and many more. We're delighted to have Dustin here to tell us about diabetes and nutrition therapy. Thank you.
Okay, so thank you guys for having me speak about such an important topic. So typically when I provide diabetes diet education to patients, it takes roughly 60 to 75 minutes. So I'm going to condense and highlight some of the main points of managing diabetes through nutrition. And so my goal is that by the end of the presentation that everyone knows the types of food that influence blood sugar levels and their appropriate portions to consume those types of food. So let's get started. So what a diabetic nutrition plan is and is not. A diabetic nutrition plan is a balanced and carbohydrate-controlled diet that consists of whole grains, fruits and vegetables, and lean protein sources. A diabetic nutrition plan is not a deprivation diet that leaves you feeling hungry. Essentially, you are consuming less of certain foods and more of others. So a diabetic nutrition plan can certainly be an appetite-satisfying eating pattern. So the goals of a diabetic carbohydrate-controlled nutrition plan: to manage glucose levels or blood sugar levels by preventing hyperglycemia, which is elevated blood sugar levels and blood sugar spikes, and by preventing hypoglycemia, which is low blood sugar levels. So we want to utilize a balanced approach to managing blood sugar levels. And to do that, we want to implement a three-pronged approach. We want to implement nutrition, some physical activity, and when I say physical activity, just basically getting out and moving more. Walking goes a long way with managing blood sugar levels. And then, of course, medications if prescribed. So the problem of solely relying on medications alone to manage blood sugar levels is that medications designed to lower blood sugar levels can deter one from making the appropriate dietary changes. So let me provide a little explanation for what I mean for that, because, these medications, again, they're designed to lower blood sugar levels. So a person could potentially consume just too large of a portion of carbohydrates or excessive sugar, and then they take that medication that prevents their blood sugar levels from spiking, and so they think, well, it could give them the false idea, of an appropriate amount of carbohydrates to consume. So an analogy that I like to provide for that is it's kind of like jumping off of a building onto a trampoline. You jump off the building, you have a nice soft landing onto the trampoline, and you get up and you say, hey, I can jump off buildings. However, if you remove that trampoline, it's going to be a hard crash. So the same thing with our nutrition, that a person may eat just too large of a portion of carbohydrates or sugar, and then they take that medication, insulin for example, and it prevents that blood sugar level spikes. So it can give them the wrong idea, about how many carbs that is an appropriate amount to consume at a time. So over time, this may cause dosage of diabetes medications to lose effectiveness, and leading to ever-increasing dosages of medications. So, and may ultimately cause a medication to lose its effectiveness altogether, and then which leads to multiple prescribed medications to manage blood sugar levels. So our goal should always be to be prescribed the least number of medications at their lowest dosage possible while still managing blood sugar levels. But you only want to adjust your medications under the supervision of your doctor, of course. So to do this, to keep the number of medications prescribed at their lowest dosage possible, we want to implement that three-pronged approach: nutrition, physical activity, and of course, our medications. So healthy eating and physical activity. In many cases, healthy eating and physical activity may allow for diabetes medications to be reduced or even discontinued under a doctor's supervision. So how to manage blood sugar levels with nutrition? Follow a carbohydrate-controlled eating pattern. So to do that, to manage blood sugar levels requires controlling your carbohydrate intake, and I'll speak more specifically of what that is, while eating a variety of healthy foods from all food groups in their appropriate portions. And following a carbohydrate-controlled eating pattern is a well-balanced and appetite-satisfying nutrition plan. It will not leave you feeling hungry. It will boost your energy and can even improve your mood as well. So for those with diabetes, it is important to eat 3 meals a day and consume about the same amount of carbohydrates per meal. It is also important not to skip meals when having diabetes to avoid the risk of hypoglycemia, which again, that's low blood sugar levels. Because low blood sugar levels can be just as dangerous as high blood sugar levels and can lead to blurred vision, difficulty concentrating, confused thinking, slurred speech, numbness, drowsiness, and in severe cases, it may lead to seizures, coma, and very rarely death. So, a carbohydrate-controlled eating pattern consists of an overall well-balanced plan that includes lean proteins like skinless chicken, turkey, and fish, lots of non-starchy vegetables like green beans, broccoli, Brussels sprouts, carrots, cucumbers, some fruits, and fiber-rich carbohydrates. A carbohydrate-controlled eating pattern consists of an eating pattern that is predominantly unprocessed foods. That's foods in their natural form, as nature made them. The way you see foods grow from a garden, that's unprocessed, before a food manufacturer has dumped a bunch of salt, fat, sugar, and in many cases, it's not even a real food anymore. It's a food-like substance. So it's the processed foods that get us in trouble. And so, processed foods are without excessive added sugars. A carbohydrate-controlled eating pattern consists of an eating pattern that includes small portions of fiber-rich, complex carbohydrates, and limiting refined grains, sugar, sweets, and sugar-sweetened beverages. So, we want to be consuming carbohydrate-containing foods in small portions. Often we hear in moderation, but that's a relative term because what's moderation to me is not necessarily moderation to you. I think it's more accurate to specify in small portions. So because carbohydrates have the greatest influence on our blood sugar levels, significantly more than fat and protein do. Carbohydrates not only influence blood sugar levels, but they also have the greatest influence on triglycerides, potentially causing a person's triglyceride levels to become elevated, and that can lead to the plaque buildup in the vessels and arteries that causes vascular blockages. So, what is a carbohydrate? It's a chain of sugar molecules. So if you think about a chain, and each link on that chain is an individual sugar molecule, and you link those individual sugar molecules together to form a chain, that is what a carbohydrate is. And your body has to digest and break that chain down into its individual sugar molecules before it can absorb it and use it for energy. There are different types of carbohydrates. And all carbohydrates cause a rise in our blood sugar levels, potentially also raising triglyceride levels. But not all types of carbohydrates equally influence blood sugar levels. So the types of carbohydrates and which ones to choose, we have the fiber-rich, complex carbohydrates, and then we have the processed refined carbs and concentrated sugars. So when we consume those fiber-rich complex carbohydrates, it gives us a slow, gradual rise in our blood sugar levels. So that's normal. That's what we want. But when we consume those processed refined carbs and concentrated sugars, it leads to a rapid spike in our blood sugar levels, which of course is what we're wanting to avoid. So an analogy for how consuming the different types of carbohydrates influence blood sugar levels. When we consume those fiber-rich complex carbohydrates, and I'll get more specifically into what those are, but when we consume those fiber-rich complex carbohydrates, it's like when you're driving in your car and you get up to the speed limit and you just put it on cruise control and you're giving your car a nice, steady supply of fuel. Versus when we consume those processed carbs and concentrated sugars, it's like punching the gas pedal in your car and just flooding the engine with gas. So we want to be choosing those fiber-rich complex carbohydrates. And because fiber slows down the absorption of sugar into the body, that's a good thing because it gives the body an adequate time to manage and process that incoming sugar, which provides that slow, gradual rise in our blood sugar level and prevents the blood sugar spikes. So some examples of those fiber-rich, complex carbohydrates that we want to be choosing are legumes like black beans, pinto beans, kidney beans, navy beans, whole grains like whole grain bread, whole grain pasta, oatmeal, brown rice, quinoa. Sweet potatoes is a really good fiber-rich carbohydrates. Now, we don't want to add sugar to that, but when we're talking about just a sweet potato itself, that's a really good type of carbohydrate to consume. Acorn squash, butternut squash are really good types of carbs. And even those starchy vegetables like white potatoes, peas, and corn. Now, of course, when we consume those more starchy vegetables, we want to consider what other carbohydrate-containing foods that we're having with those other starchy vegetables, just so that the grand total isn't too much to manage our blood sugar levels. And of course, fruit. Fruit contains natural sugar, so it's considered one of those carbohydrate foods. But it's a good type of carbohydrate that we want to choose as our carb. And again, we want to be limiting the processed refined carbohydrates, because processed carbohydrates are easily digested by the body and quickly absorbed into the bloodstream. So the body doesn't have time to process and manage all of that incoming sugar, again, leading to the blood sugar spikes. So some examples of those processed, refined carbohydrates, just think of foods made out of white flour. So like white bread, pizza crust, crackers, pretzels, white pasta. Your body can break those processed carbs down very quickly and absorb the sugars very quickly. So some examples of concentrated sugars that we want to limit, if not eliminate, are sweets like cakes, pies, cookies, candies, pastries, donuts, ice cream. Again, your body can just soak those sugars up very quickly. And sugar-sweetened beverages like soda, sweetened tea, fruit juice, sports drinks, etc. The sugars and sugar-sweetened beverages, your body does not have to digest. It's in liquid form, and it just soaks it up like a sponge. And my number one recommendation for just general health, whether a person has diabetes or not, is to get away from the sugar-sweetened beverages. Just consider beverages with added sugar as liquid candy, because their sugars are absorbed very quickly, causing rapid blood sugar spikes. So, a diabetic diet consists of a carbohydrate-controlled eating pattern. Therefore, we want to be choosing fiber-rich, complex carbs like whole grains, beans, sweet potatoes, acorn squash, butternut squash, fruit in small portions, and significantly limit the processed carbs and concentrated sugars. So, now that we've talked about the types of carbohydrates and which ones to choose, which ones to limit, we need to know more specifically, we need a method for tracking how many that we're taking in at a time. So the amount of carbohydrates to consume for blood sugar management depends on age, size of body frame, level of physical activity, weight management goals, and medications. The simplest method for tracking our carbohydrate intake is follow the diabetic plate method. And what this does, when you look at the plate on the right side of the slide, it divides your food and your drink into 4 sections. And it tells you what each section is, how much of your plate to fill it up with. And so whenever you're looking at this plate, that section 1, the green section, are the non-starchy vegetables. So non-starchy vegetables are like broccoli, green beans, peppers, leafy greens, and non-starchy vegetables are very, very low calorie. They have no fat, very, very low carbohydrates. They will not spike your blood sugar levels. So when you're looking at this plate, you can see that those non-starchy vegetables take up half the plate. 50% of the meal, you want to consist of non-starchy vegetables. So that's the key, and what that does is it starts to take up space in your stomach, starts to satisfy your appetite, which then allows you to cut back on those higher calorie, fatty, and carby foods. So section 2, the protein foods, that red section, which would include your meats, preferably a lean meat like skinless chicken, turkey, and fish, but you want to try to keep your meat portions where they take up no more than about a quarter of your plate. And then that section 3, the carbohydrate foods, those foods that we've been talking about, the yellow section, you want to try to keep those foods that are rich in carbohydrates where they take up no more than about a quarter of your plate. And then off to the side, section 4, the blue section, that's your drink. Of course, you don't want your drink to have any sugar in that. Again, just consider that liquid candy. But the key to making this plate method work is that section 1. You really want to double and triple up on those non-starchy vegetables. So a more effective method for tracking our carbohydrate intake is based on measuring portions and counting grams of carbohydrates. Because most people can visualize what a half a cup looks like or 1 cup looks like, but when we're looking on a nutrition label, a nutrition label lists calories, fat, sodium, carbohydrates, protein, all of those things. Well, on a nutrition label, carbohydrates are shown in grams. So we can more accurately track our carbohydrate intake in terms of measuring portions and counting grams of carbohydrates. So in terms of measuring and grams, 1/2 cup of a carbohydrate food, not all foods, just those carbohydrate containing foods, 1/2 cup of a carbohydrate food is equivalent to about 15 grams of a carbohydrate. So therefore, 1 cup of a carbohydrate food would equal about 30 grams of carbohydrates. So 1.5 cups would equal about 45 grams of carbohydrates. So every 1/2 cup gives you another 15 grams of a carbohydrate. So therefore, if you can visualize the measurements, then you can approximately estimate how many grams of carbohydrates that you're taking in, with your meals and snacks and throughout the day. So some examples of that would be 1/2 cup of mashed potatoes gives you about 15 grams of carbohydrates. So therefore, 1 cup of mashed potatoes would give you about 30 grams of carbohydrates. And so, to give an example of a combination of carbohydrate-containing foods, suppose we consumed 1 cup of pinto beans and 1/2 cup of corn for a total of 1.5 cups of carbohydrate foods. That would provide approximately 45 grams of carbohydrates. So it's a pretty simple method. So these next several slides, I want to give all of you specifically an appropriate amount of carbohydrates to consume per meal and per snack based on body size, which is essentially height. So what I'm going to do is I'm going to go through and call out specific ranges of height. So I want you guys to listen to your specific height, and then I will give you an appropriate amount of carbs to consume with your meals and with your snacks. So for very small framed individuals, so that would be those of you who are 5 feet tall or less. I want you guys to listen, and you can allow yourself 1 cup of carbohydrate foods per meal. So that's for each of your 3 main meals. 1 cup of carbohydrate foods for breakfast, 1 cup with your lunch, and 1 cup with your dinner. And that's equivalent to about 30 grams of carbs per meal. And then for your snacks, we don't want to consume as many carbohydrates for those in-between meal snacks as we do our meals. So for a very small framed individual, you could give yourself about 1/2 cup of carbohydrate foods, or 15 grams per snack. And if you look at this plate on the left of the page, that has roughly about 1 cup of carbohydrate foods there. It's got about a half a cup of some beans and a half a cup of what looks like some quinoa, and then it's loaded with the non-starchy vegetables and a source of protein that looks like a serving of chicken. And when you look at this plate, that is certainly an adequate amount of food to satisfy a person's appetite. You know, a very small-framed individual that would consume such a meal like this isn't going to walk away feeling hungry. So again, a diabetic nutrition plan is an appetite-satisfying nutrition plan. So a daily sample of carbohydrate intakes for very small-framed individual, again, those of you who are 5 feet in height or less, you can see here with the 3 main meals, breakfast, lunch, and dinner, you can allow yourself the 1 cup of carbs or 30 grams, and then it gives a couple of snacks. You can see that it allows you a half a cup of carbohydrate foods or 15 grams. So that's just an example of how to distribute your carbohydrates out evenly throughout the day. So for small-framed individuals, so that would be those of you between the heights of 5 feet 1 inch and 5 feet 5 inches. I want you guys to listen closely, and I'll give you, specifically how many carbs you can have with each meal and with each snack. So for those small-framed individual, you can allow yourself 1 cup to 1.5 cups, or 30 to 45 grams of carbohydrates per meal. That's for each of your 3 main meals. And for your snacks, you could give yourself about a half a cup, or 15 grams per in-between meal snacks. And this is a daily sample of carbohydrate intakes for small-framed individuals and what that looks like. You can see for the 3 main meals, breakfast, lunch, and dinner, you get the 1 cup to 1.5 cups, or 30 to 45 grams of carbohydrates per meal. And then for your in-between meal snacks, the half cup, or 15 grams per snack. So for those of you medium-framed individuals, that would be between the heights of 5 foot 6 inches and 5 foot 9 inches. I want you to listen closely, because you can allow yourself 1 cup to 1.5 cups of carbohydrates per meal for each of your 3 main meals, and a half a cup to 1 cup of carbohydrate foods, or 15 to 30 grams per snack. So you get a few more carbs with your snacks there. And this is a daily sample of carbohydrate intakes of what that looks like. So again, those of you between 5 foot 6 inches and 5 foot 9 inches in height, you get the 1 to 1.5 cups, or 30 to 45 grams per meal, and then a half a cup to 1 cup, or 15 to 30 grams per snack. So for medium-large framed individuals, that is going to be those of you between the heights of 5 foot 10 to 6 foot 1 inches in height. You can give yourself 1.5 cups, or 45 grams of carbohydrates per meal, each of your 3 main meals, and then 1 cup of carbohydrate foods, or 30 grams per snack. And this is a daily sample of carbohydrate intakes for medium-large framed individuals. Just basically an example of how, again, to distribute those carbs evenly throughout the day so that you're not consuming too many at one time. So for breakfast, lunch, and dinner, 1.5 cups, or 45 grams for medium-large framed individuals, and for your snacks, about 1 cup or 30 grams per snack. For large framed individuals, that would be those of you 6 foot 2 inches or taller in height. So for larger framed individuals, you can allow yourself, your body requires more energy. So you can allow yourself a little more carbohydrates than some of the smaller framed individuals. So for large framed individuals, again, that's those of you 6 foot 2 inches in height or greater, you can give yourself 2 cups of carbohydrate foods, or 60 grams of carbohydrates per meal. And that is not restrictive if you're choosing those good fiber-rich carbohydrates. But now if you're choosing the processed carbs and your drink has sugar in it, then it can be difficult to stick within that limit. And then for your in-between meal snacks, you can have about 1 cup of carbohydrate foods or 30 grams of carbohydrate foods for your in-between meal snacks. So that's specifically an appropriate amount of carbohydrates that you can consume with each meal and each snack based on your frame size. And I like to give people all of the information, specifically exactly how much to consume, but not everybody's going to walk out of here and count grams of this and grams of that. And if that is the case, then we can fall back on the simplest method, the diabetic plate that divides our food and our drink up into 4 sections, and we're trying to make half our plate, 50% of our meal, those non-starchy vegetables like green beans and broccoli and Brussels sprouts. Try to limit our protein portions, basically our meats, where they take up no more than a quarter of our plate. And then section 3, those carbohydrate foods, we're trying to limit those carbohydrate-containing foods where they take up no more than about a quarter of our plate. And then, of course, we don't want our drink to have any sugar in that. But the key to making this plate method work is that section 1, the non-starchy vegetables. You can eat a ton of non-starchy vegetables. Again, non-starchy vegetables are like green beans, broccoli, Brussels sprouts, cabbage, carrots, cucumbers, peppers, tomatoes, leafy greens, zucchini. You can eat a ton of those non-starchy vegetables, keep your calories down, the fat down, and the carbohydrates down, and manage your blood sugar levels all at the same time. So thank you guys for having me.
Thank you, Dustin. I really appreciate that. Very helpful in the way you categorize people according to height, which is very important. So I want all 3 of the expert panelists to come down to the front here. We'll begin the Q&A in a few minutes. Let me get them settled, and I'm trying to get a few questions, and continue to send those to Jay or whoever. And while we're waiting here, again, I want to thank Jay Ripley and Billy Clark from CAMC Education for coordinating all this, and the marketing and other support that makes this really happen. And I also want to thank Chris Cobb and Jason Likens for the superb job they've done with the technology and the audiovisual support, which I think added tremendously to what we've been able to present to you. I hope this has been useful, and I think this next part may actually be more helpful. Is Jay, you got any for me, Jay? You got them, okay. I could ask my own question, but I think you've probably got better questions here. Let me just get a few of these.
We're on the front and back.
Okay, thank you. All right, now what I'm going to do is throw these out, and Chris, everybody's got their own mic, or perfect? Okay. The first question is there a chart showing suggested good and bad foods for diabetes and recipes? I know Dustin probably is the one to direct that question to. I'm sure he showed us some charts, but is there anything else that might be helpful?
Well, there's a lot of good resources online that provides information on diabetes. A really good website is diabetes.org. And it provides just lots of good advice and tips, as well as recipes and things like that. But yeah, there's an endless number of charts out there for the types of foods that you want to choose and limit when it comes to managing blood sugar levels and diabetes.
Great, thank you. Next question, the new drugs, the SGLT-Z and GLP-1. If my physician wants to put me on metformin for diabetes, should I ask if he should look into one of these newer drugs? I don't know if that's for Dr. Sewell and possibly
Yeah, I think I'll
Dr.
handle
Rahman
that.
as well.
Dr. Rahman, too. Metformin's still a great drug, and it really plays a complementary role, particularly in lowering the glucose levels. Does not have as strong data in terms of specifically addressing progression of kidney disease or heart disease, but it's a fine drug. It's very safe. I think if you're looking at the latest guidelines, and those guidelines just came out this year, you really want to look at, do you have a compelling indication to reduce your risk of heart failure, of kidney failure, and of cardiovascular events like stroke and heart attack? And not saying it's inappropriate to use metformin in that situation, but you could ask your doctor about that. And yeah. So there's all sorts of things that come into play in terms of there are conditions that make those types of drugs maybe not indicated for you. There's also cost and coverage concerns, but I think it's a perfectly reasonable thing to ask your doctor about.
Thank you. And I know they can be expensive.
Yeah.
Asif?
Yeah. I was just going to mention a fallacy is that metformin causes kidney disease or kidney failure. Metformin should be stopped if your kidney function has deteriorated to the point where it should be stopped. And physicians know that, but it does not actually cause kidney problems.
Great. Next question. Are there other tests besides A1C to diagnose diabetes?
So, yeah, A1C is a very easy test. It can be done on non-fasting blood. So you go to your doctor after lunch, or after breakfast. It's not something you have to fast for. So that's a nice advantage of it. The other two major things we rely on are fasting glucose. So this is when you go to your doctor after an overnight fast. And the third thing that's often, well, not often used anymore, but there's a glucose tolerance test. So very, very commonly used in pregnancy to diagnose gestational diabetes. It's a little bit cumbersome because you have to go to the lab. You drink a glucola, it's called. It's very similar in amount of carbohydrates to it as a 20-ounce Mountain Dew, so don't drink Mountain Dew. But in any event, it's a little cumbersome. You've got to stay there for a couple of hours and have your blood sugars drawn several times. So those are the main three ways that we diagnose diabetes. Often your doctor can look back through old lab records and say, wow, I'm seeing a lot of blood sugars above 126 in the morning, or wow, your sugars are running in the 200s, and they can be pretty confident you have diabetes just based on that.
Thank you. If diabetes is controlled, will neuropathy in the feet subside or disappear?
It can sometimes. Unfortunately, there is a little bit of irreversibility to that, particularly as it gets more advanced. A lot of people will complain that their neuropathy gets acutely a little worse after their sugars spike up, so that's something you can try to avoid. Unfortunately, we do have several medications that can blunt the pain, but to some degree, like Dr. Rahman was saying, we really want to get on the front end of things and slow them down before they get to be problems. But in terms of neuropathy, I think if you had really exquisite control, you could prevent and maybe improve a little bit, but once it's established, sometimes it's something that you can't get rid of. There's a lot of things to be aware of with neuropathy. There's a lot of prevention type things you want to do. So particularly if you have significant numbness in your feet, you remember those little fishing lines your doctors sometimes tickle your toes with? If you can't feel those, you really need to be very cautious. Check your feet daily, making sure there's no sores that you don't feel. Consider always wearing house slippers so you don't step on tacks or splinters that you don't feel. And keep on trying to keep the glucose down because we want to prevent any further progression.
As a retired surgeon, I never look forward to looking at diabetics' feet who came in with an issue, because it is very problematic if they haven't taken care of them. The point is, I'm not you've got to be careful even after, if you have neuropathy, it may be get a bit better, or at least stabilize. But you've got to take superb care of your feet if you want to keep them, because once you start cutting on them, it's usually not a good story in the end. Good question. We talked about prediabetes in the initial stages of the presentation. Please explain what prediabetes is and what the specifics of making that diagnosis and what the pathophysiology going forward.
So the pathophysiology is probably very similar to actual diabetes. You're usually losing sensitivity to insulin in such a way that the body's not responding and getting the glucose down and into the tissues where it can be stored. Very similar pathophysiology. In terms of how it's diagnosed, there's different thresholds. So you can talk about prediabetes as being impaired fasting glucose. So if your glucose is in between 100 and 126, that's impaired fasting glucose. There's also impaired glucose tolerance, where your blood sugar is above 140 after a glucola test, but less than 200. And then the big one that this is usually diagnosed with is, again, the A1C. So an A1C less than 5.7 is normal. Between 5.7 and 6.5 is considered prediabetes. The main concern with prediabetes, well, there's several concerns. Number one, it can progress to diabetes with all the attendant things that we talked about. And then number two, people with prediabetes, just like people with diabetes, have an increased risk of heart problems. So too, to a lesser degree, to people with prediabetes. So it makes you want to be really more attuned to keeping the cholesterol down, keeping the blood pressure down, working on the diet and the exercise and the smoking and all the things that Mr. Holmes and Dr. Rahman talked about. In terms of progression, that program I talked about that's at the CDC showed that just the lifestyle measures alone were able to reduce the risk of progression by about 50%. So I think if I had prediabetes, I would try to follow that program and really follow up closely with your doctor, make sure your A1C is doing okay, that you're you can have your urine checked for protein as well. Keep an eye on the cholesterol. I hope that answered the question.
I think so.
Yeah.
For sure. I got two questions here for Dustin. The first one is how do artificial sweeteners fit into a nutritional plan?
Okay, so artificial sweeteners are a controversial subject. We have two schools of thought there. We have one school of thought that says artificial sweeteners are fine, no problem, and then there's another school of thought that says that artificial sweeteners have their own adverse effects. So there are, seems like every other week there's another study coming out, and they're typically small studies. I don't think the jury's quite out on artificial sweeteners, but it seems like every other week there's a new study coming out that suggests that artificial sweeteners actually increase the risk for heart events. And there is a phenomenon where artificial sweeteners can basically cause delayed hunger cravings to set in. Because whenever we consume something sweet, we take in a carbohydrate and our body senses that sweetness. It sends a signal to the pancreas basically to release insulin to manage that sugar. So when we consume artificial sweeteners, our body senses that sweet taste. And so then the pancreas releases the insulin. However, the sugar never comes. So it could clear out, what sugar is in our system, potentially leading to low blood sugar levels. And then when blood sugar levels get low, we get hungry. And then we may end up basically overcompensating and consuming too many carbohydrates, which would defeat the purpose of an artificial sweetener anyway. But so that's, it's certainly a subject that you can do your own research on and decide if you want to choose to consume artificial sweeteners or not.
It's to be determined, it sounds like. But you're right. Every week or so, there's something about one or other of the artificial sweeteners that gives you pause. this is another one, I guess, for you, but anybody else can chime in as well. How does caffeine affect diabetes or diabetes medications?
It's funny, I've got diabetes, but I drink a lot of coffee. It doesn't seem to do anything to my blood sugars, but I have a lot of patients who have spikes in their blood sugars in the morning, and the only thing I can really pin it on is their coffee. So I'd be curious what Dustin sees, but I've seen that it does tend to have an effect. I'm not sure why it seems to have an effect in some people and not others, but.
Right, theoretically, I mean, black coffee, it has no sugar in it, so it should not have an effect on our blood sugar levels. But like you said, those sweeteners, a lot of the flavored coffee creamers and things are loaded with quite a bit of sugar, and of course that could cause a rise in your blood sugar levels. I typically tell people if you're going to have coffee, maybe just a little half and half would be okay, and just not to include the sugar.
One thing I'll say along those lines, a lot of the patients I treat have type 1 diabetes, so they don't have really any ability to modulate insulin to bring sugars down when there's any kind of problem at all. And one of the things that I think happens is a lot of people, you tend to be more resistant to insulin, including the background insulin you're injecting if you have type 1 diabetes. You tend to be more resistant in the morning. So some of the spikes, I think, might be related to that. We call it dawn phenomenon, but sometimes people seem to have a spike there. But I definitely have, I don't know how to explain it, but I've seen people that, I said, well, cut out your sweetener, stop putting that French vanilla sweetener in there. It's really spiking your sugars, and they still have issues sometimes. But I will say, by the way, agree with all the ambiguity about artificial sweeteners, and whether or not you want to drink them, do your own research. I've been trying to steer away from them myself, but I can tell you that one of the dynamics I see is people say, well, they're both bad for you, so I might as well drink a lot of soda. And I can guarantee you that it's very, very hard to control blood sugars if you quench your thirst with sweetened beverages. I don't know if I'm sure that's something you see in your practice all the time with.
Yeah, and typically the things that we basically expose our taste buds to is what we're going to crave. So even an artificial sweetener, we're exposing our taste buds to something very sweet. So that craving for sweetness is going to persist. So ideally, we want to have that expectation that everything that we drink doesn't have to be sweet. Can't go wrong with water, of course.
That's for sure. Couple of questions about one of the newer drugs. You touched on these a little earlier, but this is about the specific drug, Trulicity, about the positive and negative aspects of Trulicity, and I guess what can be done about the availability of diabetes meds, for instance, for Trulicity. Is it hard to acquire? I did not realize that. So maybe that's another one of the negatives.
Yeah, so Trulicity is one of the GLP-1 drugs. Going back to that complicated slide about treatment, is one of the GLP-1 drugs that's been shown to have cardiovascular benefit, but the GLP-1 drugs in general cause weight loss, particularly at higher dosages, and apparently that's so attractive that people are just using it a lot. That's what the drug companies say, that our drug is so good and makes people so skinny that we can't make enough of it. But it's been a real problem. Availability for all the GLP-1s has been problematic. So we've had to switch people from Trulicity to Ozempic to Victoza to Mounjaro. All those drugs are very good drugs. And I know it's very, very frustrating to patients, and I can't tell you how much time our office spends on switching people, calling around to pharmacies, trying to find availability.
Well, it begs the question for me. You hear that you can use is it the magic bullet for everything? Is that what they're trying to tell us now?
Yeah, I think the thing that's really captured everybody's attention is the weight loss.
Sure.
So and there's a lot of people who take it just specifically for that. They're maybe not diabetic, and that is the that is the explanation I've heard talking to people in the pharmaceutical industry about why we can't always have availability to those.
I mean, are there good studies, any good controlled studies that dealing with the weight loss outcome?
Yeah, they're very, very, very effective at weight loss. I mean, so usually, so for instance, not so much Trulicity, but Ozempic and Victoza, they're marketed at much higher dosages with different trade names, so that it's Wegovy or Saxenda. They're marketed just specifically for weight loss. And those medications are really effective, particularly for people who are very overweight. You know, they start to approach, the newer ones are, the one that's related to Mounjaro is called, oh my good, does anybody remember? Thank you very much, Zepbound. I mean, the efficacies of that are starting to approach, you know, bariatric surgery. So unfortunately, A, there's a lot of availability problems. B, a lot of insurance companies won't pay for it, and the reason they won't pay for it is C, they're pretty profoundly expensive. I mean, the cash prices, you know, approaches $1,000 a month. So
Have they been used long enough to see the side effects that maybe in the long term?
yeah, I know there's been a lot in the news lately about what they call Ozempic stomach, and you'd see it with other things, with gastroparesis. So yeah, they're serious drugs with profound you know, side effects potentially. You also want to be careful about them if you have a history of thyroid cancer or gastroparesis. On the other hand, you know, going back to Victoza, which came out in the 2015 kind of era, I mean, it has been shown to help reduce weight associated with decreased cardiovascular risk. So, you know, you're starting to see advocacy groups and even health insurers say, yeah, we really probably want to get our patients on these medications for their reduction in outcomes. But they're serious medications. They're not something to be trifled with without your doctor's input.
Thank you.
But,
Question for Dr. Rahman. Why are physicians not getting patients' blood pressure to 120/80 and using a systolic of 130 to 135?
They're afraid. They're afraid. They are comfortable with what they have learned over time and have not kept pace with the new data that shows that lower the blood pressure is safe and does prevent heart attacks and strokes.
Can the systolic be too low?
If you are standing up and get dizzy and about to pass out, it's too low.
Okay.
So in the kidney world, we say bring your blood pressure down to 120 or lower, and even lower if you can tolerate it. We always add that. So if you can tolerate a systolic blood pressure of 106, that's better than 118.
Okay. Good answer. Thank you. I got a question here. Maybe I don't really. Antiplatelet therapy, please explain. Was that mentioned in one of the slides?
It may be in that pyramid of mine, and what it says is that there is a thrust to something that Dr. Soul had mentioned, this cardiovascular protection. In the end, we are protecting our heart and blood vessels from having strokes and heart attacks and all the rest. And there is a trend now to start also giving an aspirin to people who are at risk of developing these heart attacks and strokes. So somewhere along the ways, if you have a cardiologist, they may slip you an aspirin a day to prevent that from happening. But only if there is an increased risk and there is no contraindication to these medicines.
This is a card with multiple questions. I'll ask one or two of them. Can anemia worsen the risks for diabetic kidney disease due to more protein filtered in urine?
No. Anemia is a result of kidney disease. So the worse your kidney disease, the worse your anemia. So what happens in kidney disease is we all in this room, our kidneys produce a hormone called erythropoietin that works on our bone marrow to produce red blood cells. If our kidneys are failing, they stop or decrease the production of. So anemia is a result of kidney disease rather than the other way around.
Let's see. Regarding dietary revision, does fasting, which we hear a lot about these days, have beneficial effects upon diabetes, type 2 diabetes patients?
So fasting, or just essentially going long periods of time without eating, taking in any food, runs the risk of low blood sugar levels, particularly when you're taking a medication. If a person skips breakfast or lunch and we're mid-afternoon and haven't eaten anything, our blood sugar levels are already dropping and getting lower, and then you take your medication on top of that, and then your blood sugar levels can really plummet. So, and all kinds of things happen when we go long periods of time without eating, is that when blood sugar levels get low, again, we get hungry. And then when we finally do eat, we overindulge and we eat too many carbohydrates in one setting to manage blood sugar levels. So the idea is that we are spreading our carbohydrates out evenly, eating our 3 main meals per day, and keeping our appetite in check, because once appetite gets out of control and we get hungry, hunger overrides all logic and reason. And then we are likely to make some poor choices. So I'm not a big proponent of necessarily fasting. It really depends. There's different windows of when people eat. I think, maybe a 12-hour window where we eat, and then a 12-hour window of fasting is an adequate amount of time to fast. But otherwise, again, if we go too long without eating, we run the risk of low blood sugar levels.
Question, I guess from one of your slides. Dairy, why is it no longer on the food pyramid?
We really don't even follow the food pyramid anymore. It's kind of outdated. We follow more of the plate method, where it just shows, because it's more applicable, and because we look at the food pyramid and that doesn't translate to a plate of food. So now we refer to that plate method, and where it just tells us how to divide our food up into different categories, how much of our plate to fill it up with. And the plate method does give a serving of low-fat dairy.
Thank you. This is a question about testing. What is a good glucose reading first thing in the morning before breakfast? And what is a good glucose level 2 to 4 hours after a meal?
So general rule of thumb, less than 120, 80 to 120 is what's often said. You can have blood. 80 to 120 is a good general rule of thumb for fasting. Certain situations like the younger woman who's pregnant, you'd want it to be lower than that. But in general, that's a good rule of thumb. In general, we like to try to keep the blood sugars less than 160 or 180 2 hours after a meal. That can be really, really hard, but that would be a good rule of thumb. And if you can achieve that, that would get you to an A1C of about 6.5 or 7%. Okay? And going back to what Dustin was saying earlier, is that really your choice of foods can have a really profound effect on that. If you're checking your sugar, I would encourage you not just to check in the morning like a lot of people do, but to check some later in the day, particularly after your largest meals. You can really learn how different carbohydrates will have really profoundly different impacts on your blood sugars. It can be very surprising.
Thank you. Here's a question that feeds off I guess some of your comments, Dr. Soul. So it says, I guess this is in the form of a question. So you can be non-compliant with ADA as long as you take enough medication to keep the A1C down.
Well, I think I was trying to say that if you look at the ADA guidelines, they start with diet and exercise. No, you really can't. Now, there are some people who are earlier on in diabetes who can eat amazingly poorly and still suffer consequences of weight gain and unhealthy changes in the blood vessels. And you can address that with medication. But, you know, I can tell you that it's one of the most frustrating things that we deal with is having to give more and more medications to address people eating more and more. And this is a problem that we've, in the past, created a lot ourselves. We used to only have medications that increased insulin one way or the other. Before the late 90s, we didn't even have metformin, so it was all insulin-inducing medications. And, you know, somebody's blood sugars would be high. They'd get insulin. It would improve, but invariably, they would be low sometimes. They'd eat more. They'd gain weight, and it was kind of a cycle that was very, very hard to get off of. So, no, you got to eat well. But.
And then the all-important question, how about alcohol and diabetes mellitus?
So I would say I'd be curious what the other folks say too. I think I'm more and more concerned about, you know, 10 years ago, 20 years ago, oh, you should drink red wine, it's good for you. But just like the artificial sweeteners, it seems like the preponderance of these studies coming out are saying, you know, maybe less alcohol is more. As a general rule of thumb, just some things to think about. Some people say a little bit of alcohol might lower the blood sugar a little bit. This is obviously a low carbohydrate alcohol, like a dry wine or something like that. I think I would probably not advise somebody to drink alcohol for the health benefits at this point. Well, that was something that was done not too long ago. What I will point out, particularly with type 1 diabetes, or if you're on insulin, it's type 1 diabetes is a complicated illness, very much so for the patient. And to me, it's a lot like driving. I mean, if you're gonna drink, don't drink to the point that you can't operate your vehicle or take care of your type 1 diabetes. So that's a kind of a conversation I have to kids going off to college. Is, you know, unfortunately, you can get yourself into some really health-threatening situations really quickly with diabetes, particularly if you're on insulin or some of the other drugs that can cause low blood sugars. So is that the answer everybody wants?
I guess we all took that as we want to take it, I
What are they saying
believe.
in dietary circles now about alcohol? It seems like there's been more concerned about, it used to be good for dementia risk, and now they're kind of pulling back from that and that type of thing. I don't know if you've had any updates.
Well, there was always that, you know, that a little bit of alcohol consumption in moderation can reduce the risk for heart disease. But they're starting to find, they're kind of backing off of that recommendation, that they're starting to find that those studies, which were funded by the alcohol industry, were flawed studies. And if you look into it, they're based on what's called a J curve. And to try to explain that, basically, a little bit of alcohol consumption may reduce a person's risk of heart disease slightly more than someone who drinks no alcohol at all. However, as soon as a person exceeds that small amount that may receive some benefit, the risk for heart disease spikes. And we do know alcohol creates inflammation in the body, you know, and inflammation is devastating to all systems of the body, the heart, the kidneys, all systems of the body. So there is that factor. And also, alcohol increases the risk for cancers and all kinds of things. So even if we were, say, getting that slight benefit to the heart, which I'm not sure that I subscribe to that, but even if we were, there's other increased risks, again, such as cancer. So, and of course, alcohol leads to impaired judgment. And so, I mean, how often, you know, do we drink a little bit of alcohol and get the munchies and just start raiding the cabinet for all the processed salty snacks and sweets and things? So,
I think that answered their question. Thank you. This is my last one, and this I think is primarily for you, Dustin. How important is how long you take to eat? In other words, how quickly you eat. Does that affect blood sugar and the
So
effects of blood sugar
amount
on
of
the
time
rest of your body.
that you're consuming your food,
Correct.
I'm not sure that I have the answer to that. I mean, of course, the quicker that carbohydrates and sugar enter our body, the more quickly that they're going to be absorbed and cause a rise in our blood sugar levels. So, I mean, of course, consuming a portion of carbohydrates within 5 minutes is going to get absorbed a lot quicker than if it got spread out, say, over a course of 20 to 30 minutes. But I'm not real confident in answering that question.
Yeah, that's a tough one. Okay, I think this is going to be the last question. Can a regular doctor deal with diabetes, or do I need an endocrinologist?
Yeah, I mean, there are not enough endocrinologists, and there's a lot of diabetes. Primary care doctors can do a great job with diabetes, particularly type 2 diabetes. Maybe I'll offend some people. I think if you have type 1, I would seek out somebody. Now, there are people who are in primary care and they decide, gosh, I really am interested in diabetes, and some of those docs are the best in the world, literally best in the world at type 1 diabetes. But, you want to have somebody, if you have type 1 diabetes, I would encourage you to be with somebody who's really into it, that they're using. They're able to download the sensors and the meters and talk to you about pumps and things like that. But yeah, I'll tell you, that question about you can eat whatever you want is in the back of my head as I'm going to say this. The newer medications, so the people who are on these GLP-1s are getting the equivalent of what we used to call multiple daily injections in terms of efficacy, where people used to have to take shots before each meal to keep their blood sugars from spiking. And the nice things about these newer medications is they're really very, very easy to use compared to insulin. So I think it's really putting primary care in a great place to be able to address the pharmacotherapy. And again, big shout out to dietitians and diabetes educators, because you can turn very difficult to treat diabetes into fairly easy to treat diabetes by addressing. This isn't for everyone, for sure, but in a substantial number of people, they just really need some help to know what to eat, what not to eat, and you can really, really make it a lot easier for your family doctor or internist to help you out with your diabetes. So.
Thank you so much. And I want to thank our three expert panelists for doing such a wonderful job. Please give them a hand. I asked most of the questions. I'm certain that they will stay around for a little while. If your question wasn't answered, or if you have a question that you'd prefer to ask more privately, but if that isn't too much to ask of them to hang around just for a little bit longer. I want to thank everybody for coming. I want to thank you for your attention. I want to thank you for your wonderful questions. I think this made this a much more informative evening by doing that. I know that Jay has been passing out the diplomas. This is a med school, so you have a diploma. If you want to frame it, by all means, do that. But the other thing is, unfortunately, I don't know whether the virtual people, and I want to thank you for attending as well. They certainly weren't able to ask any questions, but hopefully they'll get a diploma. Will they get surveys, Jay? Will there be surveys sent out? Because it's very important for you, if you can at all possible, take a few minutes, because it really helps us to know how we did, and it also helps us to plan for the next go-round, which hopefully will be sometime this fall. But again, thank you so much for coming, and stay healthy, and by all means, take a few minutes to talk with our panelists if you have a time. Good night.
Please take your